2, 1. Please start, sir.
Okay. So very good evening. Very good evening, sir. And in this
Good evening.
new week masterclass clinical conversation, we are going to invite our first speaker in this session, Dr. Animeshwar, who is a senior consultant, has a very rich exposure previously with the Tata Medical Center, Kolkata, and other parts of the country, and also in other parts. And right now, he is associated with the Apollo Multi-Speciality Hospital, Kolkata. We are going to invite Dr. Animesh sir for his first session in choosing ARPI wisely in MHSPC patients. So very warm welcome on behalf of AR sir. Good evening, sir.
Good evening, everyone, and thank you, Sarnik and NATCO team, for giving me this opportunity to discuss
Sir,
on
sir, it's
the.
Bayer sir.
Sorry.
Yeah.
So,
I know
yeah,
it's
I'm still.
a recall that no, I know.
Yeah, sorry about that. So, yeah, thank you, Bear, for giving me this opportunity. So, let me share my slide.
Yes, yes. Sir, can you please on your cam, sir? Your slide is visible. You are not visible.
Yeah.
Yeah, right. Fantastic, sir. Okay.
Yeah. Thank you. So, choosing ARPI wisely in metastatic hormone-sensitive prostate cancer and translating data into real-world decision. So that's going to be the today's topic, and these are my disclosures. So when we start a patient of metastatic or recurrent prostate cancer on treatment, what are the major concerns? Because most of those patients are very elderly patients, and 63 to 84% patients have de novo metastatic disease. These patients are somehow often well functioning, commonly asymptomatic to mildly symptomatic, and key priorities in their case is not only extending their life because they're already elderly, but also they want to live their life with minimal disturbance. So they want minimum side effect and they want to maintain their daily activities. So when choosing this treatment, we need to consider patient characteristics, tumor characteristics, clinical evidence, patient's preference, socioeconomic factors, and all this in combination before we start them on treatment. So the treatment of metastatic hormone-sensitive prostate cancer has evolved beyond ADT since long time, starting from the days of Chartered and Stampede Arm C, where docetaxel used to be used with ADT. Then Latitude came into the picture in 2017 with abiraterone plus ATT, along with Stampede Arm G. And then enzalutamide came in the form of Archies and Enzamet study, and then apalutamide in 2019 with Titan study. And now triplet combination is coming into the picture since 2022 with ARPI, ADT plus docetaxel being introduced in Enzamet study and Peace-1 study. And now we have got Aranote, where ADT plus darolutamide has been used, and Aracin, where darolutamide plus ADT plus docetaxel being used. So these are the key study of ARPI with ADT. And if you see the current recommendation, all options are there in hormone-sensitive prostate cancer with single agent ARPI plus ADT. And now with whether it's high volume, low volume, and younger fitter patient, we are more keen to use triplet therapy, which has shown better outcome with either abiraterone, docetaxel plus ADT or darolutamide plus ADT plus docetaxel. So how to navigate difference between this guideline and what is our day-to-day practice? That's the question. So let's look at some of the key clinical trials. It is ARCHES, where enzalutamide versus placebo was tested in de novo for recurrent metastatic prostate cancer. It is TITAN study design, where apalutamide versus placebo was considered. This is LATITUDE, where abiraterone was established in de novo metastatic or hormone sensitive or recurrent prostate cancer. And now coming to the main trial, ARANOTE study. This was done in metastatic hormone sensitive prostate cancer with good performance status 0 to 2. And they were stratified between visceral mets present or absent prior local therapy. And they were randomized 2:1 between darolutamide 600 mg BD plus ADT versus placebo plus ADT. And their primary endpoint was relapse-free radiological progression-free survival. And there are plenty of secondary endpoints, including overall survival, time to initiation of subsequent therapy, time to CRPC, time to PSA progression, and many things. So in ARCHES, there is significant improvement in radiological progression-free survival preceded by an overall survival benefit with enzalutamide in the final analysis. The median PFS, RPFS was about 14.4 months, and median OS was not reached. In TITAN, you can see the wide gap between the Kaplan-Meier curve between radiological progression-free survival, and it was also significantly better with apalutamide. In LATITUDE, similar story. So what ARANOTE is providing, ARANOTE demonstrates that darolutamide plus ATD provides robust clinical benefit with favorable tolerability profile for the patient. It reduces the risk of radiological progression or death by about 46%, which was statistically significant. Darolutamide was associated with deep and durable PSA response. You see that this depth of response is also correlate with the overall survival. It reduces the risk of death by about 90%, 19%. It is the only study in metastatic hormone-sensitive prostate cancer to show lower discontinuation rate in the treatment arm versus placebo. This is interesting. And it also reduced the risk of progression to CRPC, castrate-resistant prostate cancer, by about 60%. Darolutamide reduced the risk of pain progression by about 28%. And treatment-related adverse events were pretty similar between the two groups, including hypertension, fatigue, rash, bone fracture, mental impairment, falls, etc. And patient in ARANOTE trial had 4 times higher baseline PSA than TITAN and ARCHES. And undetectable PSA level was achieved in 2/3 of the patient of hormone-sensitive prostate cancer patient receiving ARPI. So a closer look or the radiological progression-free survival as a primary endpoint in trial. Radiological progression-free survival is positively correlated with clinical outcome, including overall survival in randomized clinical trial. So how do I monitor response and disease progression in patient? Mainly PSA, and as per the guideline, 3 to 6 monthly. Clinical signs of symptoms, conventional imaging, sometimes PSMA PET, sometimes not routinely. And this is what the guideline says. Yeah, PSA physical or clinical assessment and PSA monitoring is generally recommended across guideline 3 to 6 monthly. NCCN did recommend that PSMA PET CT or PSMA PET MRI can be considered as an alternate to conventional imaging. AUA guideline also recommend can be considered conventional imaging, but as per the UAE, ENAM, ISTRO, ISAR, ISAP, SIOG combined guideline, until further data are available, MRI PET CT should not be used outside clinical trial for treatment monitoring. So achieving undetectable PSA level is associated with improved OS benefit that we are getting with the darolutamide in this aeronaut trial. Minimizing side effect and maintaining quality of life are key treatment goals for patients with metastatic hormone-sensitive prostate cancer. And if you look at the side effect of different ARPI, you see the overall toxicity, all grades toxicity, and grade 3 and higher toxicity. These are the toxicity of enzalutamide, mainly hypertension, fatigue, arthralgia, back pain, increased weight, diarrhea. These are the common side effects. Although the all grade side effects are there, the grade 3 and higher side effects are pretty low, similar in apalutamide. The rates of most common adverse effect with darolutamide and ADT were low, and it was similar to placebo plus ADT, confirming darolutamide's favorable toxicity. But to be honest, it is hard to compare this toxicity with other ARPI. And these are the safety data from reported metastatic hormone-sensitive prostate cancer studies investigating ARPI. You can see any treatment-related adverse event, serious adverse event were pretty similar. Grade 3 or higher toxicity were slightly higher in the Titan study. Grade 5 toxicity were pretty similar. Treatment discontinuation was also pretty similar in number. Median duration of treatment was highest with darolutamide. So these are the commonly seen side effect or precautions that we consider while prescribing somebody with ARPI. The list is pretty long in abiraterone, and enzalutamide and apalutamide had pretty similar side effect profile. And there are many, the list is minimum in darolutamide. Still, we need to consider ischemic heart disease, history of seizure, and embryo-fetal toxicity. And as you know that all these prostate cancer patients are pretty elderly, they do come with a different metabolic syndrome problem like diabetes, hypertension, high cholesterol. Often there is like mental issues like depressions and all. So they are often on multi-drug therapy for other different medical problems. And it is quite important that we understand that CRPI can have significant drug reaction with this commonly used drug like calcium channel blocker, proton pump inhibitor, antipsychotics, antibiotics, antithrombotics. And this drug interaction has been shown to be minimal with darolutamide. So this is quite important while choosing the ARPI. So in conclusion, immediate intensification of ADT with ARPI should not be delayed. So ADT alone is no longer a treatment of choice. Addition of either docetaxel or ARPI improve PFS, PSA response, and delay progression. Although we now have triplet therapy, which are commonly used in younger fitter patient. Favorable toxicity profile, convenient management, and different DDI profile are relevant consideration in prostate cancer patients. While this rapid therapeutic evolution is welcome, it presents clinicians with a crucial challenge, the choice of treatment selection and sequencing, and it is upon us how to choose ARPI and to justify the use based on the clinical benefit, side effect profile, drug interaction, and many other profile, and choose the best suitable option for that particular patient. That's all for me. Thank you for your kind listening.
Thank you, sir. Thank you to Dr. Animesh, sir, for his very nice and deliberate presentation. Why it is very important to choosing the ARPI, particularly for the elder age patients. So very much thank you, sir, just being with us. We will come with your permission. We are going to come with our another speaker. So I'm going to invite Dr. Devapriyo, sir, who is senior consultant medical oncology from the Fortis Hospital, Anandapur, Kolkata. So, welcoming Dr. Devapriya sir for his session on MHSPC to MCRPC. How can we delay the inevitable? So very welcome, sir. Good evening, sir.
Good evening, everyone. Thank you for having me in this session today. After this elaborate and very perfect presentation and clear demonstration of the evidence that we have in metastatic hormone-sensitive prostate cancer in terms of doublet and triplet therapy, it is my work to discuss the next topic. I thank the organizers and Dr. Animesh Shah.
Sir, your slide is not moving particularly possibly.
So from MHSPC to MCRPC, can we delay the inevitable? So the standard disclosure and so the standard of care for MHSPC is ADT plus one of the ARPIs that we have. And irrespective of timing of metastasis, risk, volume, burden, and co-administration of docetaxel, there is no role of intensification with docetaxel alone as demonstrated by PIS1 and Aracin. So we do not use a doublet with docetaxel and ADT anymore. So early intensification strategy in metastatic hormone-sensitive prostate cancer. It started with docetaxel. We have the charted study, the Stampede, the GETAG 15 study. And in these studies in high volume disease, the role of docetaxel was significant. If you look at the current European urology guidelines, in metastatic prostate cancer, continuous ADT and adequate life expectancy, these things need to be ensured. And after that, if it's all yes, then if it is a low volume disease, then there is role of doublet therapy for most patients, and in some cases, upfront EBRT to the primary tumor can also be discussed. Now, in a high volume disease, and also in certain low volume situations, if high volume disease, the patient is eligible for docetaxel, fitness permitting, the patient is willing, and all those, then triplet can also be considered in form of either ADT plus docetaxel plus abiraterone or ADT plus docetaxel plus darolutamide. So, docetaxel eligibility, this is important. This is something that decides whether the patient will be considered for a triplet, although docetaxel is not the third drug. Which patients with MHSPC benefit from docetaxel? A systemic review and meta-analysis of individual patient-level data from randomized trials. Effect of docetaxel on OS and so in low volume metachronous and low volume synchronous. So high volume synchronous, this is perhaps the population that benefits the most if we look at meta-analysis and individual patient level data. An effect of docetaxel on OS for patients with high volume disease has been demonstrated time and again. So the standard of care for any MHSPC is ADT plus one of the androgen receptor targeting agents, irrespective of the time of metastasis, risk volume, and co-administration docetaxel. And there is no role of intensification with docetaxel alone. But ASCENS was the only study prospectively designed to investigate the combination of darolutamide plus ADT with docetaxel in MHSPC. It's a global randomized double-blind placebo-controlled phase 3 study. And it included patients with ECOG performance status of 0 or 1. And stratification was extent of disease, that is M1A versus M1B versus M1C, alkaline phosphatase level. And in one arm, it was docetaxel 6 cycles with darolutamide plus ADT. In another arm, it was placebo plus ADT along with docetaxel 6 cycles. Docetaxel was the common treatment modality in both the arms, because at that point, the charted treatment with docetaxel in upfront disease, that was standard of care. So we can't say that we do not have a study that is takes a triplet versus a doublet with RP. That is something that is the evolving treatment strategy, which was not there at the time the first patient was recruited to the study, not November 2016. So the primary endpoint was overall survival, and the secondary endpoints were time to castration resistant prostate cancer, time to pain progression, symptomatic skeletal event-free survival, time to first symptomatic skeletal event, time to initiation of subsequent antineoplastic therapy, time to worsening of physical symptoms of the disease, time to initiation of opioid use for more than 7 consecutive days, and of course, safety. The first cycle of docetaxel was administered within 6 weeks after the start of the study drug at the discretion of the investigator. So PIS-1 was not prospectively designed to investigate the combination of abiraterone prednisone plus ADT with docetaxel, because it was a multi-stage, multi-arm trial with different treatment options coming in a different. So this trial included de novo M1, recurrent metastatic disease, so PIS-1 did not include recurrent metastatic disease. It did not include patients who had prior chemotherapy, and disease extent definition was high volume and low volume. ECOG performance status was less than 1. And pooled SOC group was arm A was standard of care. Standard of care was ADT alone, then ADT with radiotherapy, and there was SOC plus abiraterone plus prednisone, and there was SOC plus abiraterone plus prednisone plus radiotherapy. So ACC was ADT or ADT plus docetaxel at different times. This one is a 2 into 2 factorial design that takes into consideration the evolving standard of care. So November 2013 to 2015, ADT alone. In November 2013 to 15, ADT alone. 2015 to 17, docetaxel permitted as standard of care. From 17 to 18, docetaxel mandatory as part of standard of care. In adolescents, on the other side, all 1306 patients enrolled received docetaxel versus 710 patients, that is only 61% in phase 1. So adolescents had recurrent or de novo MHSPC. The primary endpoint was OS. Stratification factors were extent of disease and alkaline phosphatase level. Docetaxel plus ARP, 100% patients had received docetaxel in both the arms, and exclusion criteria were more realistic, like recent stroke, AMI, severe unstable angina, coronary or peripheral artery bypass graft, and congestive heart failure of NIH grade 3 or 4. Piece 1, it was de novo MHSPC only. The primary endpoints were OS and radiologic PFS. And stratification factors were many, like type of castration, LHRH agonist versus antagonist, ECOG PS 0 versus 1 or 2, extent of disease, and docetaxel ES versus no. The SOC evolved from ADT alone to mandatory ADT plus docetaxel during the trial, and 61% patients received ADT plus docetaxel as standard of care. Hypertension not controlled by treatment, recent AMI and other arterial thromboembolic events, atrial fibrillation, other cardiac arrhythmia requiring therapy, history of pituitary or adrenal dysfunction, and patients who couldn't receive steroid were excluded from the trial. In adolescents, darolutamide plus ADT with docetaxel significantly reduced the risk of death by 32.5%. And if you look at the patients who are alive at 48 months, 4 years, it is 63% versus 50% in ADT plus placebo plus docetaxel compared to the combination triplet with darolutamide. With the addition of darolutamide, the 4-year survival rate increased from 50 to 63%. And the validity of early treatment intensification with combination is supported by the results from piece 1. And abiraterone plus prednisone plus ADT with docetaxel significantly improved OS compared to docetaxel plus ADT with a risk reduction of 25%. Unlike piece 1 adolescents, there was early separation in the Kaplan-Meier curve, and the lines remained separated over time. So if we just go back, we can see all along there was a clear separation, and the magnitude of benefit is also much more, although these are cross-trial comparisons, but the survival curves look completely different for adolescents and piece 1. So patients in the darolutamide arm stayed on treatment more than 2 years longer than patients in the placebo arm and had a similar discontinuation rate due to adverse events as those with placebo. Duration of treatment in adolescents, it was darolutamide plus ADT, it was 41 months, placebo plus ADT, it was 16.7 months. If we look at the duration of treatment in piece 1, then it is 34.1 months, and treatment discontinuation is much higher at 17%. When we look at darolutamide versus placebo, then it is, it looks like exact same, and darolutamide also has almost the similar rate of discontinuation as placebo. So darolutamide did not affect the ability to complete the full 6 cycles of docetaxel, and 87.6% patients completed the planned 4 cycles of docetaxel. And placebo plus ADT plus docetaxel, this was 85.5% patient. And Piece 1 does not report the proportion of patients who completed all 6 cycles of docetaxel. In adolescence, the incidence of any grade adverse events was similar in both arms. So the darolutamide did not increase any grade adverse events. And the severe or grade 3 or more adverse events, they were also similar, with just slight, not similar, much higher in abiraterone plus docetaxel plus triplet compared to docetaxel by ADT, particularly if you look at hypertension, which is attributable to abiraterone, that was much higher. 22% patient had grade 3 or higher hypertension. 6% has hepatotoxicity, which is grade 3 or higher. So in adolescence, the incidence of adverse events of interest were generally similar between the treatment arms. All the metabolic disorders and hypertension and cardiovascular incidence, they were same. And cerebrovascular ischemia, more importantly, it's not there. Incidence of rash and hypertension were higher in the darolutamide arm than the placebo arm. It was not very high. So there is no role for intensification with docetaxel alone, as demonstrated by piece 1 and adolescence. APCCC 2024 panelists voted on questions regarding the use of systemic triplet therapy. And 54% opined that in patients with high burden MHSPC, who are fit for chemotherapy, 54% of the panelists recommended a triplet, and 40% recommended only in selected patients. So, and 6% did not recommend this treatment. So overall, around more than 90% patient voted in favor of triplet therapy, either for majority or at least for selected patients. In patients with low burden MHSPC that are chemotherapy fit, this was only mostly panelists wanted this to be in selected patients. And in asynchronous disease, that is metachronous disease, this was not supported by most of the panelists. That is what we find from all the studies. So safety consideration for doublet and triplet therapies, what to consider with doublet therapy, monitoring with abiraterone required like hypertension, edema, LFTs, hypokalemia. There is pill burden because of, it's 250 into 4 pills, exacerbation of ADT, adverse events. There is cardiovascular, cognitive, and bone health decline. And when we add triplet to that, there is infusional treatment, there is chemotherapy toxicity, there is administration time. All considerations associated with doublet therapy are also there. So the take-home message is 2 studies, piece 1 and adolescence demonstrated that ADT plus docetaxel is not enough, and the addition of another androgen receptor signaling agent or pathway inhibitor improves survival. Additional intensification with a triplet combination, that is with an APRI and RP and ADT with docetaxel, should be considered as a new standard of care in patients who are fit and can be selected for this. To proactively manage adverse events of the new treatment options, it is very important to understand the toxicities of each of these agents. Multidisciplinary care is key to success. All eligible patients should be offered the benefit of the newer standards of care to enable living with preserved or improved quality of life. So with that, I come to the conclusion of our talk today. Thank you.
Thank you, sir. Thank you very much. Thank you for your nice and deliberate presentation, sir. So if there are any kind of any query or any questions to Dr. Devepri and Nonini sir, if they are from the audience, so we'll request. So we can wait for just a minute. So I think there is no any queries from right now. So we can go for conclude the session. So thank you very much for being with us in this session. Thank you all our speaker. So we are going to conclude the session now. Thank you, sir. Thank you, Devapriya sir and Anand sir.